She was called the unsinkable ship. At over 880 feet long and weighing 46,000 tons, it was at the time the largest movable man-made structure on Earth. As the Titanic departed from Southampton, England on April 10, 1912, who would have guessed that the ship's final destination would have been a deep, watery grave on the floor of the North Atlantic? A powerful cautionary tale about the perils of human hubris? Or an apt metaphor for the timely treatment of hypertension? I'll let you decide as I recount the events surrounding the sinking of the Titanic. At 11:40 p.m. on the 14th of April, the lookout spotted an iceberg immediately ahead of Titanic and alerted the bridge. First Officer William Murdoch ordered the ship to be steered around the obstacle and the engines to be put in reverse. But it was too late. The starboard side of the Titanic struck the iceberg, creating a series of holes below the waterline. 5 of the ship's watertight compartments were breached, including the number 6 boiler room. It soon became clear that the ship was doomed. Let these exposed high-pressure pipes in the boiler room remind you of our recurring sketchy symbol for the treatment of hypertension. In this sketch, we're going to cover your usual outpatient treatment of primary hypertension, as well as acute management of hypertensive emergencies. But before we reenact this tragedy, I'd first like to focus on some of the first-class amenities provided for, about 96 hours on this one-of-a-kind vacation cruise liner. The first-class section had a gymnasium, a squash court, a Turkish bath, and of course, a swimming pool. It's all happening on the primary deck. And this is where we'll depict the first-line drugs used to manage primary hypertension. There is no uniform agreement as to which antihypertensive drugs should be given for initial therapy. The major options are thiazide diuretics, ACE inhibitors or ARBs, and calcium channel blockers. Initial monotherapy is successful in many patients with mild primary hypertension. Patients who start out with blood pressures more than 20/10 millimeters of mercury above goal, however, may need a little extra help. Single drug therapy in these patients is unlikely to attain blood pressure goal, and initial combination therapy using 2 drugs is recommended. Hence our kindly reminder that 2 life preservers are recommended when aiding fellow passengers who are more than 20 pounds overweight. Another thing to keep in mind when choosing an antihypertensive regimen is that some patients have an indication for a specific drug that is unrelated to primary hypertension. For example, a non-dihydropyridine calcium channel blocker or beta blocker for rate control and AFib. That drug they're on is also treating their hypertension. In the absence of a specific indication, though, remember these 3 main classes of drugs: thiazide diuretics, long-acting calcium channel blockers, and ACE inhibitors or ARBs. One of the most widely used agents as initial monotherapy is low-dose hydrochlorothiazide, a diuretic that causes sodium and volume loss at the distal nephron. Well, hydrochlorothiazide will be represented by this kid on the high dive as he immediately realizes the irony of partaking in a leisurely swim at the very moment that the Titanic plunges toward the ocean floor. Take a look at those pasty yet muscular thighs. His chloro speedo, along with those glaring thighs, will be a recurring theme for hydrochlorothiazide. Though commonly used, hydrochlorothiazide may actually be less effective than a related agent, chlorthalidone, which has been shown to reduce cardiovascular events. So just keep that chloro speedo in mind, but get accustomed to seeing chlorthalidone on a patient chart instead. Stay tuned for more info on the mechanism of action of these ubiquitous diuretic agents in our hydrochlorothiazide waterslide sketch. Alright, each of the first-line antihypertensive agents is pretty much equally effective in lowering blood pressure. However, there is wide interpatient variability as many patients will respond well to one drug but not the other. Black patients and elderly patients, for example, often respond best to a thiazide diuretic or long-acting calcium channel blocker. See this black gentleman here, determined to enjoy the first-class amenities even as the deck crumbles behind him? Honestly, I'd also want to savor every last bite of that all-you-can-eat calcium from the soft-serve machine, our recurring theme for calcium channel blocker therapy. Specifically, long-acting dihydropyridines are most commonly used. These vasodilating agents end with that dipping suffix, so we've incorporated it into the sign for the dippin' pool. And since thiazide agents can also be especially useful in Black and elderly patients, he's showing off those unmistakable hydrochlorothiazide thighs, with matching chlorospeedo, of course. Another commonly used agent for treatment of mild primary hypertension is an ACE inhibitor. If you recall, we learned about how this agent interrupts the renin-angiotensin-aldosterone cascade in the April Showers casino sketch. Well, our ACE-stealing deck-stacking dealers are back, manning the poker tables on deck. Remember, too, that ARBs, which directly inhibit angiotensin, are related agents that are also helpful in the initial treatment of hypertension. Many elderly hypertensive patients will have a specific indication for an ACE inhibitor or ARB, such as heart failure, diabetes, or previous MI. So let's sketch in our recurring floppy, sad-looking heart failure balloon, the broken heartstrings myocardial infarction banjo, as well as a sweet diabetes-inducing candy jar. Just a quick recap of a few clinical settings when ACE inhibitors are first-line therapy for treating concomitant hypertension. And you know what? On the exam, treatment of primary hypertension will often focus on those other conditions affecting the patient that should guide your choice of antihypertensive therapy. For example, think back to our previous sketches that highlighted the cardiac remodeling process associated with chronic heart failure. In the back of the beta blocker symphony hall, in the chapel at the ACE inhibitors and ARBs casino, and on one of the closed rides at the Nephron Fun Zone and Water Park, next to our spironolactone health inspector at the food court. This one you might not have seen yet, but we'll get to it during our diuretic unit. Anyways, all these agents provide survival benefit to patients with heart failure and combat cardiac remodeling, making them the first choice therapy for treating hypertension complicated by heart failure. Also, remember all those previous sketches where we featured the angina anvil? The anvil xylophone at the beta blocker symphony? And those anvil ice cream bowls at the calcium channel blockers soft serve shop? These are antihypertensive agents that double as effective therapy for stable angina. The outpatient treatment of primary hypertension usually involves trying to find the simplest drug regimen to which the patient is most responsive, with minimal side effects and maximum compliance. Over time, more than one drug will be needed in many patients who are initially controlled. Despite the large number of patients with chronic hypertension, hypertensive emergencies are relatively rare. A marked or sudden elevation in blood pressure may be a serious threat to life. And like water gushing through a breach in the hull of the Titanic, hypertensive emergencies require prompt attention and control. Therefore, we've sketched in the boiler room attendant rushing over to our recurring sketchy symbol for hypertensive emergency treatment, the emergency shutoff switch. The clinical scenario will go something like this. A 55-year-old man with a history of chronic hypertension arrives at the ER with blurry vision, lung crackles, and pressures of 195 over 115. There are two important components to this question stem. First, increased blood pressure is usually deemed a hypertensive emergency when systolic is over 180 or diastolic is over 120. Let this 180-degree protractor over a 12-inch ruler on a workbench in the boiler room remind you of pressures rising above 180 over 120. Second, our patient is showing acute ongoing signs of end organ damage, which can include blurry vision, lung involvement, or even neurological symptoms. And if a 200-foot hole in the Titanic's number 6 boiler room isn't a representation of end organ damage, I don't know what is. So we've got pressures above 180 over 120 and end organ damage. What do we do? Well, there are a few options. It's generally unwise to lower blood pressure too quickly or too much. This can cause ischemic damage to areas that have grown accustomed to the higher levels of blood pressure. For most hypertensive emergencies, pressures should be reduced gradually, by about 10 to 20% in the first hour and by a further 5 to 15% over the next 23 hours. And while the sinking of the Titanic took only about 3 hours, I think that's enough time to highlight a few of the medications often used to manage hypertensive emergencies. Okay, we all know the story from here. 5 of the ship's watertight compartments breached. The deck of the Titanic began to slip under water as her stern rose out of the ocean, causing the massive vessel to break in two. And with only enough lifeboats for about half the passengers on board, the band played on, going down with the ship. Up on deck, you'll witness the swan song of the members of our Beta Blockers Symphony sketch, the Beta 1 Buglers. Remember that the rousing bugle represents those heart-activating beta 1 receptors. When muted, they represent beta-1 receptor antagonists, such as esmolol and metoprolol. These beta blockers are given IV to rapidly bring blood pressure under control, hence the IV covering the deck of the ship. In fact, all the agents discussed here used to manage hypertensive emergency are given IV in the acute setting before switching to oral antihypertensive therapy for long-term control. Labetalol is another parenteral beta blocker used in the acute setting. Remember though that labetalol sounds like both alpha and beta. See the alpha and beta labeled stops that our organist uses to modulate flow to the pipes? Labetalol exerts both alpha and beta antagonistic effects. Recall from our beta symphony sketch that beta antagonists lower blood pressure by directly decreasing heart rate and contractility. With labetalol's extra alpha-1 blocking effects, however, it's also a potent vasodilator. Not only that, take a look at the smokestack over here at the center of the sketch. It's big, red, dilated, meant to evoke an image of a ridiculously huge, open, and dilated artery. That's because all these agents we're about to discuss, besides the aforementioned beta blockers of course, cause potent vasodilation, aiding in the rapid reduction of peripheral resistance, thereby lowering pressure. There are two important consequences of this to keep in mind on the exam. First, this significant reduction in peripheral vascular resistance can eventually lead to hypotension, which when sensed by the body triggers a reflexive sympathetic response. This consists of reflex tachycardia in addition to a reflexive increase in sodium and fluid retention due to direct stimulation of renin release by the kidney. See our budding internist aiding a fellow passenger who's collapsed from excessive hypotension? He whips out the old heart-shaped reflex hammer. That's our recurring sketchy symbol for reflex tachycardia. It's 1912. What's he supposed to do? It's like science and stuff. Anyway, our young doctor further highlights reflexive sympathetic activation by holding the renin rain umbrella. Whenever you see that big open yellow umbrella, remember that renin is getting released, leading to increased sodium and fluid retention. The other important consequence to remember from all this vasodilation is a decrease in the small artery and arteriolar resistance that the heart has to push against, and so a decrease in afterload on the heart. Whenever we want to show afterload reduction, we include a scale that reads load. And in this scene, afterload is getting reduced by our passenger here, hastily throwing excess weight overboard. I don't know if that's going to help, but I like his enthusiasm, I guess. Let's go through a few more of the agents used to decrease afterload and pressure in the setting of hypertensive emergency, each represented by their own emergency lifeboat. First of all, recall from our calcium channel blocker ice cream parlor sketch that certain dihydropyridine calcium channel blockers exert potent vasodilatory effects. Well, our first lifeboat here, definitely not filled to capacity by the way, holds a lady with our recurring symbol for calcium channel blockers, a delicious cup of calcium ice cream. Specifically, a couple of the dihydropyridines are most commonly used and they're administered via IV. Nicardipine, represented by this nice card she's writing, and clovidipine, highlighted by the clover, as she wishes good luck to all those men still on board. Remember, these agents cause arteriolar dilation to reduce systemic resistance, as evidenced by her red, floppy arteriolar sleeves. I say men because, come on, it's 1912, chivalry is still in full swing, so when boarding the lifeboat, remember that it's women and children first. And I'm pretty sure that pregnant women get priority here. So let's sketch in our next antihypertensive agent used in treating hypertensive emergency. Also safe for use in pregnant women, and that's hydralazine. Represented by this hydro boat, a fire rescue vessel sent to aid the passengers. Hydralazine is a direct arteriolar vasodilator with little or no effect on the venous circulation, hence the floppy red arteriolar hose. Here's a pregnant woman being helped on board now to remind you that the use of parenteral hydralazine is primarily limited to pregnant women. Recall our previous sketches where we highlighted the management of hypertension in pregnant women. the alpha-methyl-dopa rope in the secret lair of the opera house, the labetalol organist at the beta blocker symphony, and the knife-wielding nifedipine lady at the Kelsey Yum soft serve shop. These agents are safe in pregnancy and are used to treat severe hypertension while preserving uteroplacental blood flow. Notice that we've made Kate Winslet over here fainting. Keep in mind that when administering hydralazine, the fall in blood pressure can be sudden and begins within 10 to 30 minutes. The potent vasodilator, therefore, can precipitate a hypotensive response, resulting in reflex sympathetic activation. The ensuing reflexive tachycardia can actually exacerbate angina in patients with coronary artery disease. So let's sketch in our recurring angina anvil, tying down this hydralazine hydroboat. For this reason, a beta blocker is often co-administered with hydralazine in order to blunt this reflexive sympathetic response. And what do we have here? It looks like one of our beta blocker band members with his beta 1 bugle packed away is having some major second thoughts about going down with the ship. Women and children first. Screw that. Well, as he shoves over the doctor about to tend to our lightheaded friend over here, let that falling heart-shaped reflex hammer and closed Renin umbrella represent those reflexive sympathetic effects that can be minimized by beta blockers. It turns out that reducing afterload on the heart with hydralazine can also be useful when managing heart failure due to systolic dysfunction. So let's sketch in our recurring floppy and failing heart failure balloon. Notice, though, that it's attached to a stick of dynamite being thrown at a nearby iceberg to make way for the incoming rescue boats. Well, a lit stick of nitroglycerin is our recurring sketchy symbol for nitrates. And we've included it here because hydralazine, when combined with nitrate therapy, has been shown to provide symptomatic and mortality benefit in selected patients with heart failure due to left ventricular systolic dysfunction. Mortality benefit is highlighted, as usual, by our symbol of the guardian angel, preserving life for the souls on board this doomed vessel. The rationale for combined therapy is this. Hydralazine acts as an arteriolar dilator to reduce afterload, while nitrates act as venodilators to reduce preload. When used together, this can reduce cardiac filling pressures. We'll learn more about how nitrates venodilate to reduce preload in our upcoming sketch, The Ballad of John Nitro. One more thing to mention about hydralazine. Hydralazine can also rarely cause a drug-induced lupus-like syndrome, manifesting as arthralgias, myalgias, joint swelling, pericarditis, pleuritis, rash, and fever. So, we brought back our lupus wolf, helping out with the rescue. Oh, look, he found someone. I mean, come on. They couldn't both fit on that piece of driftwood? Really? Or take turns in the water or something? Really? Okay, where was I? Right, nitrates. So there's another nitrate agent used to manage hypertensive emergency, and that's nitroprusside, represented by this speedboat powered by nitro pressure. When administered IV as sodium nitroprusside, this agent causes systemic vasodilation almost immediately. Nitrate vasodilators work by providing nitric oxide, a gas depicted by this nitric oxide exhaust. Nitric oxide works at vascular smooth muscle to induce the generation of cyclic GMP. And whenever we want to convey increased GMP, we bring back the old GMP grump, this time looking just a little peeved about being thrown overboard to reduce weight on the ship. And I'm pretty sure that getting a face full of nitric oxide exhaust isn't helping either. Remember that nitrates are supposed to only dilate veins that return to the heart to reduce preload. This will be reiterated during our nitrate sketch in our smooth muscle unit. Well, sodium nitroprusside is a bit different in that it causes both venous and arteriolar dilation, leading to a decrease in both preload and afterload on the heart. Just think of this sailor's red dilated arterial sleeves in combination with his floppy and dilated blue venous pants. It's a bit excessive, I know, but so are the times. There's one little problem with nitroprusside. It's metabolized to cyanide. So we've placed, or misplaced if you will, an extra cyanide exhaust pipe on this gas-powered vessel, dumping cyanide right in his face. Whenever we want to convey nitric oxide gas, it will be a pleasant white-colored vapor. Cyanide gas, however, is this toxic-looking cyan or blue smoke. Especially in the setting of renal impairment or prolonged administration, toxic levels of cyanide can accumulate, leading to lactic acidosis, altered mental status, and seizures. So notice that he's looking a bit altered from inhaling so many fumes. We've also added our recurring sketchy action lines to convey the seizures associated with cyanide toxicity. Alright, the last IV antihypertensive agent we'll cover in this sketch is phenoldiprem, which will be represented, of course, by an old lady named Pam. As she climbs down this emergency rope toward the lifeboat that's waiting for her, there are a few things I want you to notice. First of all, a single rope is our recurring sketchy symbol for the dopamine 1 receptor. Phenoldiprem is a selective dopamine 1 receptor agonist with no effect on alpha or beta receptors. This results in a rise in intracellular cyclic AMP, as depicted by the camping tent erected on her lifeboat. Cyclic AMP causes vasodilation in most arterial beds, especially renal, mesenteric, and coronary. Let those loose red dilated sleeves remind you of dilated arterial beds, leading to reduced systemic resistance and afterload on the heart. She must be some kind of royalty, judging from that big dilated coronary crown, which should remind you of phenoldiprem's ability to dilate coronary vasculature. Most important on the exam, however, will probably be phenoldiprem's ability to dilate renal arteries, as depicted by the red arterial rope connecting to the kidney-shaped support at the bottom. In fact, phenoldiprem is the only IV agent that improves renal perfusion while lowering blood pressure. Not only that, stimulation of dopamine receptors in the kidneys leads to increased sodium and water excretion. It looks like she had just enough time to grab a quick salty peanut snack before evacuating, our recurring symbol for sodium. Her hands are a little full, however, with trying to save her life and all, so the sodium peanuts tumble into the ocean, just like the natriuresis induced by dopamine receptor activation. Alright, I think we just have enough time to sum up this shipwreck into a few important points. Up on the primary deck, we highlight the major options for treating primary hypertension: thiazides, depicted by those unsightly pale thighs, dihydropyridine calcium channel blockers, next to the Calci-Yum soft serve, and ACE inhibitors at the Ace Casino poker tables. Fun times! However, make sure to consider the other conditions affecting the patient, which can guide your choice of antihypertensive therapy. That way you can treat both conditions at once. The rest of the sinking ship is dedicated to the management of hypertensive emergency, defined as systolic over 180 or diastolic over 120, depicted by the 180-degree protractor above the 12-inch ruler. The other thing you need is end organ damage, which is pretty obviously shown by the gaping hole in the boiler room. Medications available for treating hypertensive emergencies include IV beta blockers, represented by the Beta Bugle Symphony, as well as IV labetalol, our recurring alpha-beta stopping organist. Labetalol, as well as all the rest of the antihypertensive agents in the emergency boats, are potent vasodilators. This is symbolized by the huge red dilated smokestack. Remember that all this potent vasodilation can cause reflexive sympathetic activity, as highlighted by the ship's doctor frantically using that heart reflex hammer under our recurring renin umbrella. Also remember that arteriolar dilation means reduced afterload, just like the load reduction going on at the side of the ship as cargo gets thrown overboard. The hydro boat depicts hydralazine. It's safe to use in pregnancy. As she faints on board, though, watch out for that angina anvil, because hydralazine can cause severe hypotension, leading to reflex sympathetic stimulation and exacerbation of angina. Adding a beta blocker can help. Let that floppy heart attached to the nitro stick remind you that hydralazine plus nitrates improve survival in some patients with heart failure, hence the guardian angel. In the top of the sketch, the nitro-powered speedboat represents nitroprusside. The GMP grump depicts how nitric oxide increases cyclic GMP to cause vasodilation. Remember, that's both arteries and veins, both afterload and preload, and both his venous pants and arterial sleeves are awkwardly baggy and dilated. Watch out for cyanide toxicity. And finally, old lady phenoldiprem climbing the dopamine rope. Activation of dopamine receptors causes arterial, coronary, and renal dilation, hence the kidney rope. She also promotes natriuresis. This sketch got pretty serious, didn't it? Maybe we should finish it off with a more lighthearted note. I know. How about a joke? What do you get when you cross the Atlantic Ocean with the Titanic? About halfway. Ooh, too soon. Too soon.